Good morning, ladies and gentlemen. On behalf of Society of Aims Mohali Anesthesiologists, I, Dr. Tanya, and along with Dr. Rangat, welcome this August gathering to Medical Conference on Current Advances in Regional Anesthesia for the Elderly, CARE 2024. We are thrilled to have each of you here as we explore the latest techniques, innovations, and best practices shaping anesthesia care for elderly patients.
This conference brings together leading experts, researchers, and clinicians to share their valuable insights tailored to the unique needs of the growing patient population. We'll dive deep into ranging from innovative anesthetic topics to improving patient outcomes. We are especially excited about our hands-on workshop designed to enhance practical skills. So without further ado, let's start our first session.
Our first chairpersons, Dr. Ritu, Associate Professor, Department of Anesthesia, AIMS Mohali, Dr. Suchet Tigotra, Head of Department, Department of Physiology, AIMS Mohali, and Dr. Ashdeep Mamam, Assistant Professor, Department of Medicine, AIMS Mohali, bring a wealth of experience and expertise to this forum. They shall be chairing the session titled Setting the Stage, Physiological Changes Associated with Aging and Its Implications for Regional Anesthesia.
So for the first session, I call upon stage Dr. Bismanjeet Kaur. She is Assistant Professor in Punjab Institute of Liver and Biliary Sciences, Mohali. I welcome you, Dr. Bisman. Her achievements include she is a DM in Trauma Anesthesia and Critical Care from PGIM Chandigarh. She has received Best Paper Award in national conferences. She has multiple research papers in peer-reviewed national and international journals, and her areas of interest include trauma, regional anesthesia, and critical care. The topic for her presentation is Setting the Stage, Physiological Changes Associated with Aging and Its Implications for Regional Anesthesia. Welcome, Dr. Bisman.
Thank you, ma'am, for the warm welcome. Good morning, everyone. My topic is physiological changes associated with aging and its implications. So, overall, there has been an increase in the elderly population all across the world from 11 to 22%. So, the National Trauma Data Bank of America, for the year of 2016, they revealed that 43% of all the patients in the registry were above the age of 55 years, and the mortality in this age group was as high as 58%. So, what is the definition of elderly? So, as an acceptable definition all across the world, they take it as a chronological age of 65 years and above. And this is further subdivided into three groups: elderly, who are between 65 to 74 years, old, who are between 75 to 84 years, and very old, who are above 85 years. Now, the WHO has just divided it into two classes. The one which states elderly who are above 65 years and oldest who are above 80 years of age. Now, another type of classification is based on their physical capacity. So they have given three classifications: recently old, who are still active and they can undertake normal activities without any support; old, who work with difficulty and have reduced activities; and very old, who work with difficulty and are restricted to home or bed. Now, we all must remember that special considerations need to be kept in mind while we are taking care of our elderly, which should include specifically the effects of age on the physiological functions, their comorbidities, and concomitant medications. Coming to the cardiovascular system, there's an overall decline in the responsiveness and density of the beta receptors. There's a progressive replacement of functional cardiac and vascular tissue by stiff fibrotic material. And there is also loss of strength, efficiency of the heart. Along with that, the heart valves become fibrotic and sclerotic, and there is thickening and reduced flexibility of the cardiac valves. There is decreased baroreflex, there's a decreased coronary blood flow, and the conduction system, the pacemaker cells are also decreased. This is primarily because of the fibrotic tissue which is increasing in the SA, AV node and the conduction bundles. Hence, these patients are always at a risk of perioperative cardiac adverse events. They are also at a higher risk of developing hypotension during the perioperative period, and their compensatory mechanisms for maintaining their hemodynamics are also decreased. Now coming to the next part, which is the vascular tissue. So the vascular tissue also has atherosclerotic changes. It becomes stiff. So these patients are hypertension is another common problem that you see in the elderly population. Should we wait or continue? ये तो on है, ये देख power off हो सकता है पीसी तो ऑन है देख रहा है इसमें ऑन है So, coming to the respiratory system. Coming to the respiratory system, there is a decline in elasticity of the bony thorax. There is loss of muscle mass, weakening of the muscles of respiration. There is a blunted respiratory response to hypercapnia and hypoxia. Overall, there is a progressive loss of vital capacity of 20 to 30 mils per year from the age of 20, and there is a progressive increase in the residual volume by 10% per decade. Now, there is also a progressive increase in the FRC, the closing capacity, and an alveolar oxygen gradient. Along with this, there is a decline in the resting PO2 levels, and gas exchange efficiency also declines with age. Hence, this age group is more prone to post-operative atelectasis and reduced diffusion capacity. Coming to the upper airway protective reflexes, the cuff effectivity is reduced, which is primarily due to the desensitization of the airway epithelial cuff receptors. The laryngeal, pharyngeal, and airway reflexes are also less effective in the older population, and this makes them susceptible for aspiration pneumonitis. Coming to the renal system, the renal vascularity is reduced. This makes them prone for renal ischemia and a higher chances of renal failure in the perioperative period in the setting of hypertension. Also, this should be taken in mind in the setting of chronic renal disease, diabetes mellitus, recurrent UTIs, benign prostatic hypertrophy, and prostatic cancer, which is more common in this age group. The overall decrease in the liver mass and the reduced hepatic blood flow results in reduced hepatic clearance. The plasma albumin concentration also decreases, which decreases the protein binding of drugs and thus leads to increase in the duration of action of many drugs. There is a slow release of increase or release in the insulin in response to hyperglycemia. There's alteration in the renin, angiotensin, aldosterone system. Subclinical hypothyroidism is also common in this age group, along with the setting of diabetes mellitus and osteoporosis. Hence, during the perioperative period, there are more chances of going into either hypo or hyperglycemia. They are also at a risk of iatrogenic hypokalemia and other electrolyte abnormalities. Now, the muscles are innervated by fewer axons, which leads to which is primarily due to denervation atrophy. There is decrease in the nerve conduction velocity, reduction in the fibers in the spinal cord tracts, and along with that, the other commonly associated diseases like Parkinson's, Alzheimer's are also very much prevalent in this population. Hence, the perioperative implications are that in the postoperative period, they're likely to go into postoperative cognitive dysfunction or delirium, and their sensitivity for opioids is also increased. Now, degenerative joint diseases are very common in this population. There is loss of intervertebral disc and associated comorbid musculoskeletal diseases like osteoarthritis, osteomalacia, rheumatoid arthritis, gout makes their surgical positioning very difficult, and they are also prone for nerve injuries and skeletal trauma during the perioperative period. Coming to spinal anesthesia, due to the calcification of ligamentum flavum, the midline approach for the epidural or the subarachnoid space becomes difficult. The myelin degeneration results in increased sensitivity to the local anesthetic, and the onset of motor blockade also increases. Sudden decrease in the preload, which is seen post spinal anesthesia, also results in increased chances of cardiovascular instabilities. Now, coming to the drug doses for the epidural. So, the doses which are required to achieve the same block level is reduced in the elderly population, as cited due to the reasons previously in the previous slide. Increased susceptibility to the local anesthetics, there is increased drug permeability, and there is also narrowed intervertebral space. Now, the elderly population is extremely prone to hypothermia due to poor thermoregulation, and due to decreased muscle mass, they are also prone for pressure ulcers or pressure stores, which is further contributed by dehydration, poor nutrition, and circulatory impairment. Now, the circulating plasma protein levels are overall decreased in the elderly population, which results in higher free drug levels and enhanced delivery to the drugs to the brain, and hence the requirement or the dosage of anesthetic drugs also reduces in this group of patients. So, the important message is to handle your elderly with utmost care. Now, coming to the important practical points. When you receive an elderly patient in your ICU, in your emergency, what are the things that you must always keep in mind? Now, this is a population that is prone to So it is very important to understand the mechanisms of injury. First, even a small fall, trivial trauma can lead to significant fractures or head injuries. Another important thing is road traffic collisions are very likely to produce more fatal injuries, and they may also lead to severe thoracic and pelvic injuries along with traumatic brain injuries and spinal cord injuries. Third, they are also prone to abuse due to neglect. The other important feature is that what we commonly see in the elderly population is pseudo stability. Now, pseudo stability is perceived stability when we feel that the observed vital signs are normal in the normal range because we compare it to the adult population. Hence, this leads to under-triaging and delayed resuscitation in these set of patients. There is also lack of recognition of hemorrhagic shock because these patients in due to severe in grade 3 or grade 4 shock show hemodynamic instability. Now here, if you have to categorize these patients, it is important that you use the age-adjusted shock index, a value of which, if it is more than 50, is very sensitive and specific for occult shock. The other most important thing is the confounders in assessment that we commonly face during when we receive these patients in the emergency, in the triage, in the OT, which are not taking care of their comorbidities and medications. Then these patients are commonly on anticoagulants, frailty, long lives where they have been neglected for long periods of time and have delayed presentation. Even accidental hypothermia in these patients can lead to small injuries. Neglect can lead to hypothermia, which may lead to patients presenting in very serious hemodynamic instabilities and delirium, which may where we contributed to the uncooperativeness of these patients. Hence, we have to be very careful, we have to be caring, and we have to be very patient when we are dealing with this set of individuals in our OTs, in our emergencies, and in our preoperative period. Thank you.
Thank you so much, Dr. Bismanjeet, for such a. You have explained beautifully all the physiological parameters in elderly people, which is really very important to understand that how the doses can be adjusted, and everything was explained very beautifully. And rightly said, handle with care is really very important, and you have applied whole the side by side. You have explained how, like for example, cuff reflex is not there, then how the chances for the aspiration is increased, and likewise. So thank you so much. And now house is open for discussion. Any queries from audience? If not, then should we move further? Thank you, Bisman.
Thank you, ma'am.
Thank you, ma'am, for enlightening us with your inspiring insights and expertise. Now, I would like to invite Dr. Pooja Saxena to kindly felicitate Dr. Sushit Trigota and Dr. Ritu Gupta. I would also like to request Dr. Pooja ma'am to kindly felicitate Dr. Ashdeep Maman and Dr. Bismanjeet. So we're done with our first session. Let's move on to our second session. For the next session, we have our distinguished chairpersons, Dr. Y.L. Narayana, Head of Department Anesthesia at PIBLS Mohali, Dr. Jitendra Makkar, Professor in Anesthesia, PGIMR, Dr. Swati, Associate Professor, Anesthesia at GMCH Chandigarh, and Dr. Kavita Agarwal, Assistant Professor, Department of General Surgery, GMCH Chandigarh. We invite these visionaries to share their valuable insights. They'll be chairing the session, Prepping for Success, the best practices in the immediate preoperative and intraoperative periods in the elderlies receiving regional anesthesia. Lessons learned from the existing guidelines. Please welcome them with a round of applause.
Good morning. Uh, as a potential patient of this sort of anesthesia, let me invite Dr. Nimish Singh. I have been classified as recently old by Bisman. Okay, so I invite Dr. Nimish Singh. She is affiliated to Homi Baba Cancer Hospital and Research Center, New Chandigarh. She has multiple publications in national and international journals, including a number of book chapters. And she is interested in critical care, difficult airway, and onco anesthesia. She is going to talk about prepping for success.
Very good morning to everyone. I am Dr. Nimish Singh, and I'll be discussing the lessons from existing guidelines for immediate preoperative and intraoperative period in elderly receiving regional anesthesia. So quickly, why is geriatric anesthesiology important? There has been a significant shift in the age of population in the age of population, and there has been an increase in absolute numbers of the elderly population in India. People aged more than 60 years were about 10.5% in 2022 and are expected to reach to about 20.8% by 2050. The average life expectancy in India last year was 70.42 years and is expected to increase in the subsequent years. The overall mortality in general population post anesthesia and surgery is reported to be 1.2%, whereas it can be up to 8.4% in the elderly. So, as the population ages, there will be a concurrent rise in the demand of surgical and anesthetic services, and the unique physiology of the elderly requires tailored anesthetic management to identify the individual risk factors which they face and to optimize their perioperative health. So, what are the challenges in the management of a geriatric patient? Geriatric patients are a heterogeneous population, and there could be a wide disparity between their physiologic age and chronologic age. There's a steady decline in their physiological organ function, and also there's potential of diminished mental capacity. They may often suffer from multiple acute and chronic comorbid conditions, and we do not always readily have their preoperative organ reserve function at our hand. They may, in the elderly, common conditions may have atypical presentations, and when they come for emergency procedures, elderly patients, they're reported to be associated with increased mortality and morbidity rates. They often take multiple medications and have so polypharmacy. That is about more than 5 to 8 medications at one point of time. So, what are the guidelines which are available for optimal perioperative management of the geriatric patients? Time and again, multiple number of guidelines have been issued, but the most recent one and the most widely followed are by the American College of Surgeons, which they developed with in collaboration with the American Geriatric Society. They came up with the National Surgical Quality Improvement Program and gave the best practice guidelines. So, for the perioperative management of the geriatric patient, we also have the guidelines from the Italian Inter-Society Consensus and from ARGB and Korean societies. But today I'll be discussing largely the ACS NSQIP guidelines. So, what do we do in the immediate preoperative management? So, at the PAC clinic itself, the healthcare team, along with the elderly and the family or the caregivers, at the PAC clinic itself, we should recognize what are the treatment preferences and goals of the patient, and here is what we have the opportunity to begin proactive post-operative planning. Plan the analgesia strategies, minimize the dose of opioids to prevent functional decline and delirium post-operatively. At the PSC clinic, we can send the patient to multi-specialty consultation when any one or more of the particular organ system is compromised. At the PSC clinic is the opportunity to involve allied health staff like the physiotherapist. We can send the patient for incentive spirometry, deep breathing exercises, improvement of their pulmonary functions, or to the nutritionist if we detect malnutrition. And at the PSC clinic, we also chart a plan for home health needs of the elderly at discharge. So, consent and end of life issues are complex in the geriatric age group and are commonly encountered. Important principle which underlies consent and decision making is autonomy, and autonomy requires mental competence. The elderly patients may have cognitive and sensory difficulties. They may suffer from dementia, depression, hearing and vision problems, which will affect the independent decision making by the elderly. Advanced directives, that is, do not resuscitate, do not intubate, or offer living will, when and where applicable and possible, should be taken into consideration. So, risk assessment and preoperative evaluation per se. For the elderly, we follow the standard risk stratifications which are followed for normal adult patients. For cardiopulmonary risk stratification, the American College of Cardiology and American Heart Association guidelines are followed. Of particular interest is functional assessment and identification of geriatric syndromes like frailty and cognition, which I'll be talking about in my subsequent slides. So, and the goal goal of risk assessment is to identify at-risk patients, carry out risk reduction strategies, and prepare the caregivers for anticipated post-operative course. So, in the preoperative evaluation is largely based on the patient's medical history, the physical examination, the type of surgery, or depending upon the disease, the comorbid disease which they're suffering from. We can order these tests: electrocardiogram if there's a history of hypertension, cardiac disease; a chest radiograph if we find pulmonary symptoms, or the physical examination warrants so. Similarly, for the other tests. So, a very important assessment in the elderly is the assessment of functional status and functional reserve. It is an important component of the pre-operative evaluation of the elderly. It refers to the ability to perform a list of tasks either independently, partially independently, or with complete assistance. These constitute the activities of daily living and the instrumental activities of daily living. And this document, it will serve as a documentation for functional improvement or deterioration. And studies have shown that any deterioration in activity of daily living increases the relative risk to 1.9, and if there is a deterioration in the instrumental activity of daily living, the relative risk ratio increases to about 2.4 for 90-day mortality in medical patients. So activities of daily living are like very simple activities like personal hygiene, continence management, dressing, feeding, ambulating, and toileting. And instrumental activities of daily life, that is the activities which add meaning to the life, like companionship, mental support, transportation, preparing meals for oneself, managing the household, managing medications, managing finances, communicating others, maybe use of a smartphone. Another aspect which is of importance in the elderly is malnutrition. The incidence of malnutrition is about 13% in elders living with families or living in community, and rises to up to 50% for elders who are in hospitals or rehab centers. Malnutrition predisposes the elderly to wound infections, anastomotic leaks, and increased postoperative length of stay. So the recommended nutritional assessment which we can make is calculating the BMI, baseline serum albumin levels, and making a note of weight loss in the previous 12 months. So if the BMI is less than 18.5, albumin is less than 3, weight loss of more than 10% in 6 months, it signifies severe nutritional risk and warrants referral for supplemental nutrition, especially for elective surgeries or surgeries in which we can delay the surgery. Malnutrition by itself is a frequent indicator of overall frailty, which brings us to what is frailty. Frailty implies a decrease in physiologic reserve across multiple systems in excess of normal age-related decline in function. Inflammatory state, autonomic and immune dysregulation is supposed to be the cause which brings about frailty in the elderly population. It impacts 7 to 10% of elderly dwelling in community, and about 25 to 56% in patients who come for surgery. The incidence of frailty is higher with age, more in women, and increases with chronic disease. And frailty is also an indicator, prognostic indicator for poor outcome, and an independent risk factor for major morbidity, mortality, and increased length of stay. So there are various tools which we have for the assessment of frailty, of which the most common is the clinical phenotype model, although it was given way back in 2001. Here we observe 5 conditions: unintended weight loss in the elderly, weakness, self-reported exhaustion, slow walking speed. You may say that I'm not that active anymore, I get tired easily, or low physical activity. Then we also have Robinson's traits for individuals undergoing colorectal surgery, which incorporates the ADLs and IADLs, which I discussed before, timed up and go test, where the patient sits on a chair, gets up, walks 10 feet and comes back, and all of this has to be done within 15 seconds. Then assessment of cognitive function, comorbid disease burden, anemia, hypoalbuminemia, and if there has been a history of fall in the last 6 months. This is we also have a clinical frailty scale available with us, in which categorizes the elderly from very fit to living with mild frailty, moderate frailty, severe frailty, and terminally ill. Then comes cognitive assessment. Patients with preoperative cognitive difficulties carry increased risk of postoperative delirium and POCD, which I will be dealt in the next lectures. Then the ACS NSQIP guidelines, they recommend doing the mini cog test, which I'll be this is the mini cog test. Then we also have to assess several this cognitive assessment is done so that we can assess several domains at the same time. This is memory, language, visuomotor skills, and executive function. Then there's the concept of comprehensive geriatric assessment has been introduced. So what is CGA? It is the systematic multi-dimensional assessment that includes medical evaluation, usually by a geriatrician, assessment of the patient's cognitive and functional status, social support, and disability. CGA has been shown to provide a valuable predictive assessment of the risk to surgery for older patients. So this is the mini cog test. The two points which we take note are the 3-word recall and clock drawing, and a score of less than 3 suggests possible impairment. So coming to preoperative fasting, for the elderly, the ASA guidelines are followed, but they do not specifically address fasting in elderly patients, but are most widely used. And as for the normal adult, they may not apply to elderly patient coming with comorbidities or diseases like diabetes, hiatal hernia. Guidelines remain the same: 2 hours for clear liquids, 6 hours for a light meal, and up to 8 hours for a heavy fried fatty meal. Antibiotic prophylaxis and venous thromboembolism prophylaxis. The recommendations are for antibiotic prophylaxis. It has shown to reduce the risk of surgical site infections and has given a mortality benefit of up to 60 days. So based on the the hospital's flora, hospital's pathogen profile, antibiotic prophylaxis should be given within 60 minutes of the surgical incision. And thromboembolism prophylaxis, the increasing age and immobility are themselves risk factors for VTE, and so based on the methods available and the institutional protocols, VTE prophylaxis should be instituted. Elderly very often will be on a number of medications, so in the pre-op clinic, we have to discontinue non-essential medications, continue essential medications, and also this is the time when we can review that what all medications the patient is on, and plan it for even for the after the discharge. Intraoperative management, the goals are to reduce adverse outcomes and to improve postoperative pain control, to maintain patient safety in the operating room, uh, to prevent perioperative hypothermia, prevention of nausea, vomiting, and safe transfer and shifting of patients. So for intraoperative monitoring, standard ASA monitoring is recommended along with advanced additional hemodynamic monitoring if the surgery is supposed to be invasive, prolonged, or if the patient is with significant comorbid conditions. The goal of intraoperative monitoring remains to maintain normotension, normoxia, and normothermia. So, for postoperative nausea and vomiting, the risk factors in that particular patient should be assessed, and the usual according to the hospital protocols or according to the guidelines, the care should be taken for postoperative nausea and vomiting. In the elderly, scopolamine, metoclopramide, and promethazine are to be avoided. It's 2 more minutes. Patient safety, elderly are particularly prone to the risk of nerve damage and pressure injuries from malpositioning due to because there is skin atrophy and there is reduced skin integrity. So patients coming for regional anesthesia or for general anesthesia, we should ensure proper positioning, padding of bony prominences, and limit the pressure on peripheral nerves. And we should also take care of the adhesive dressings, the sticky dressings which we apply. uh, they have to be removed carefully. Intraoperative hypothermia has to be prevented in the elderly. Uh, it is associated with adverse events. Core temperature should be maintained, should be monitored in surgeries lasting for more than 30 minutes, and patient warming with forced air warmers or warm IV fluids should be done. For fluid management, restrictive or goal-directed strategies are recommended, and we have to take into account the effects of aging, anesthetics, and the physiology of the elderly. So in short, elderly patients, they are vulnerable. They're a vulnerable patient group, and they're at an increased perioperative risk. They should undergo extensive preoperative assessment and a structured intraoperative management. It is said that it takes a village to raise a child. I would like to add that because it's an old adage that elderly are like children, so I would like to add that it takes a multidisciplinary team of the geriatrician, of the anesthesiologist, of the multi-specialty physicians, of the nursing officers, physiotherapist, nutritionist, to take care of the elderly and manage them post-operatively, perioperatively. Thank you.
Thank you, Dr. Nimish, for this elaborate talk. It was a very extensive coverage. However, I would like to, add that what we want to discuss more is what is the role of regional anesthesia in these patients, and what are the special precautions we can take in case we want to take up an elderly patient for regional. So the commonest surgeries which these patients we come across are hip fractures. So what is your take on the preference of GA versus regional for hip fractures? Yeah, so what do you think about it? What did you come across?
Ma'am, preferably regional anesthesia, unless otherwise contraindicated by the patient's condition. If, for example, if patient has multiple comorbid conditions, which we need to be, for example, uh, very low ejection fraction, or depending, ma'am, regional anesthesia is preferred for lower limb surgeries, for lower limb vascular
For hip fracture,
surgeries.
because this
Yes,
is
ma'am.
the
Case-based
procedure where
approach.
they we commonly come across patients, elderly patients.
Yes, ma'am.
And is there any way we can optimize these patients also? You did tell us that the BMI, if the BMI is less than 18.5, then they are at high risk of morbidity. So does this guideline tells that how can we optimize these
The
patients
guidelines say
preoperatively?
that if we detect malnutrition in the form of either reduced BMI or obesity, and if the surgery is elective, we have time at our hands, then the patient should be optimized. But if the patient is coming with a hip surgery, it is a semi-urgent surgery, we may not have enough time to optimize the nutrition for such a patient. So, but if we have the time, we should, ma'am, and it should be detected at the, or at least we should make a note and uh,
And what are the recommendations for use of anticoagulants if we take up this patient for regional anesthesia? Like supposingly we want to do an epidural in these patients. Are
Yes,
there
ma'am.
any? Does this guidelines say about?
Ma'am, these guidelines do not the recent, but the ASRA guidelines will be followed depending on the what anticoagulants patient is on, and
Okay.
the time at which it has to be stopped before the
Okay.
if
I would just like to add that you have to carefully select the patient, whether you want to give regional anesthesia or general anesthesia, and adequate technique, anesthesia technique is very important. Whether you want to give GA with block or you want to give regional anesthesia, low dose, spinal epidural, combined spinal epidural, and vigilant monitoring. All the three things, they have to be taken into account when you are practicing the best practices for regional anesthesia. Then only it is safe and will be effective and will have a better outcome. Open.
Congratulations, Dr. Nimish, for an elaborative and comprehensive session on comprehensive geriatric perioperative assessment. So, perioperative assessment, you have rightly described that it's a patient-centric and patient-focused approach which requires an integrated contribution from the anesthetist and the geriatrician. And you forgot to mention about the surgeons as well. The surgeon is equally
Yes, of
involved in the
course.
perioperative
Yes,
assessment.
yes.
And one thing I would like to highlight that the risk analysis in such patients, because these are not a normal patients, these are special cases. Risk analysis should be done in a perioperative period, should be documented to and conveyed and communicated to the patient, the attendants, and even the
that is very
surgeons.
important.
Everybody should be involved actively in the perioperative assessment. And this kind of frailty index you spoke of is a upcoming, I think, a clinical and a research tool nowadays, which has been used to
Research.
predict the outcomes in the perioperative period.
Yes.
Thank you so much.
Thank you.
Topic is open to all for any questions or discussion. Sir. Yeah, I did. So if there are no more questions, we will close the session. Thank you, Dr. Nimish, for this elaborate talk, and thank you.
Thank you, speaker and chairpersons, for sharing your expertise. I request Dr. Bharti to felicitate Dr. Y.L. Narayana and Dr. Jitendra Makkar. I request Dr. Ashwini to felicitate Dr. Swati Jindal, Dr. Kavita, and Dr. Nimish Singh. Now, I'm delighted to introduce our next chairpersons, Dr. Y.K. Batra, Senior Director, Department of Anesthesia, Max Hospital, Mohali, Dr. Sandhya, Professor and Head of Department of Anesthesia, PGI Chandigarh, Dr. Suman Arora, Professor, Department of Anesthesia, PGI Chandigarh, and Dr. Manpreet Singh, Professor, Department of Anesthesia, GMCH Chandigarh, whose wealth of knowledge and innovative perspectives promise to captivate and inspire us all. They will chair the next session, Safer Shores, Role of Regional Anesthesia in Enhancing Postoperative Care in Older Adults.
Good morning, everyone. I invite Dr. Vignesh Ashok for a lecture on Safer Shores, Role of Regional Anesthesia. He is a faculty member at PGI. He has done MD, FRCA, and he is a reviewer for various international journals. His interests are obstetric anesthesia and critical care, pediatric anesthesia, and perioperative medicine and global health. Dr. Vignesh.
Good morning, everybody. Thank you so much for the warm introduction, and thank you for the organizers for the kind invitation. So I'll be talking about the role of regional anesthesia in enhancing the postoperative care of an elderly patient. So this topic is actually quite vast, and I will not be going into each and every kind of regional anesthesia modality and talking about the evidence base. But the presentation will give you an overview of the regional anesthesia in elderly patients, and we'll be looking at some key outcome measures following regional anesthesia, and then get on to the crux of the topic, which is the effect of regional anesthesia in analgesia, how it can be incorporated into the ERAS pathway, and its specific effects on post-op delirium, cognitive dysfunction, cardiac morbidity, deep vein thrombosis, and pulmonary embolism before the conclusion. So these things have already been discussed. There's been a global increase in the magnitude of aging in the population, and in most countries, particularly in the West, the demographic pyramid is already inverted. So a greater proportion of the population who are alive are actually over 65 years of age, and more elderly patients with much more complex medical comorbidities are presenting for elective and urgent surgeries, and these patients require a much higher level of care than younger patients. So the term elderly not just includes the chronological age, but also includes the physiological age as well. So when we say regional anesthesia or analgesia in the elderly, it primarily includes central neuraxial blocks as well as peripheral nerve blocks, and have been extensively studied in orthopedic, genito-urological, gynae, and major abdominal surgeries. The largest bulk of the literature that we have is from neck of femur fractures. So 70% of the presentation will also be summarizing the evidence base that we have for neck of femur fractures in the elderly. So when we look at outcome measures, they can be classified into three: patient-related outcome measures, surgical outcomes, and institutional outcomes. Patient outcomes include things like acute and chronic pain, PONV, post-op cognitive dysfunction, post-operative delirium, and the hard data, which is morbidity and mortality. Surgical outcomes include surgical site infections, intensive care admissions, and functional outcomes after surgery, while institutional outcomes refer to parameters like length of PACU stay, length of hospital stay, and healthcare costs. Now, most of the data that we have about the benefit of regional anesthesia in elderly patients is focused on patient-related outcomes, which we'll be discussing briefly. So when we look at what are the possible beneficial effects of regional anesthesia and analgesia in the perioperative period, there's a lot of things that have been suggested. Many of that is actually theoretical. A lot of it is intuitive based on our understanding of how regional anesthesia and analgesia works. But has theory been able to translate to practical aspects? The answer for that question at this point of time is no. A lot of it is theoretical, but the evidence base for this in a practical setup is still limited and it's only emerging. So when we look at regional anesthesia in the perioperative period, it includes the preoperative, intraoperative, and the postoperative phase. And when used well, it has been shown to reduce the use of perioperative opioids, decrease incidence of opioid-related side effects, and help in fast tracking after recovery in specific kinds of surgeries. So when we look at pre-operative regional anesthesia, analgesia interventions, they've been mostly studied in hip fractures. So in the early 2000s is when the fascia iliaca block technique was identified, and it was used in neck of femur fractures, and they showed that it's quite beneficial in the pre-operative period, and it helped patients get more comfortable while they wait for surgeries. It improved their pain management. It reduced preoperative consumption of opioids and also reduced preoperative incidences of opioid related side effects. So it was not just the block that was identified to be useful, but also the time to block that came to become an important key performance indicator to evaluate how well our geriatric anesthesia services were. So the earlier the patients received a block in the ER or the emergency room, the better was the preoperative outcomes in these studies. And subsequently, a systematic review showed that regardless of the local anesthesia or the regional anesthesia technique used, ultrasound guided peripheral nerve blocks had a definitive role in the preoperative management of pain in elderly patients who underwent hip fractures. And not only these, preoperative regional analgesia interventions also helped in better patient positioning. So patients could sit up in the bed while they wait for surgeries, which definitely had improved outcomes on their pulmonary function as well. They could also be mobilized better for imaging services, like, for instance, when they had to be transferred from the bed to the trolley to be taken up for a urgent CT or an X-ray, that helped. And the preoperative use of regional analgesia techniques also showed a beneficial effect in patient positioning for spinal anesthesia in the intraoperative period as well. But when we come to intraoperative anesthesia, this is where the literature gets a little murky. So when we look at regional versus general anesthesia, two of the largest systematic reviews and meta-analysis that we have today, one of it published in 2023 and the other published in 2024 in the Canadian Journal of Anesthesia, shows that there is no difference in mortalities in patients who have received general anesthesia or regional anesthesia for hip fractures. However, the use of regional anesthesia has been associated with a reduced incidence of intraoperative hypotension, reduction in intraoperative time, intraoperative blood loss, and better postoperative pain scores. But this did not translate into better improvements in overall postoperative mortality, both at admission at 30 days as well as in 60 days. So the guidelines that we have, which is the most updated, is the 2020 guidelines given by the AAGBI. And I didn't refer to the American guidelines because that was given by a school of surgeons. This is the latest that we have, which is developed by anesthesiologists. And these guidelines declare that the difference in any outcome between the anesthesia types is likely to be very small in comparison to the effects of outcome of the trauma itself, the surgery done, the patient factors, and the kind of geriatric anesthesia care that's been provided. So the authors opine that a single 1 to 2 hour anesthesia window is unlikely to have an impact on hard outcomes, but that's true if and only if the anesthetic was conducted well. So how well anesthesia was delivered is likely to be more important than what was the kind of the anesthetic that's provided. But the guidelines has a strong emphasis on the use of peripheral nerve blocks for analgesia regardless of the overall anesthesia plan. So even if patients have a spinal, the standard of care is to give a spinal with a block, usually a fascia iliaca nerve block. And similarly, even if patients have a general anesthetic, whether with an LMA or with an endotracheal tube, they all got peripheral nerve blocks in the form of a fascia iliaca block. So when regional anesthesia was done well, its effects extend into the postoperative period as well. And multiple studies as well as systematic reviews have shown that the use of regional analgesia or anesthesia techniques have definite effect over the postoperative course. They use much less opioids, suffer much less from opioid-related side effects, and patient satisfaction was also higher. So another group of patients in whom regional analgesia has been evaluated is elderly patients undergoing colorectal surgeries as part of the ERAS pathway. So before the ERAS came into being, epidurals were the standard of care for regional analgesia techniques, but however it was shown that it was not very useful and in fact caused more patient harm. So the current guidelines for the colorectal ERAS pathway recommends the use of a single shot spinal with intrathecal opioids, and the use of an abdominal wall block, such as a rectus sheath block or a TAP block, not as a single shot, but as a catheter. Commonly, it can be given by the surgeons or by the anesthetist as well. So moving on, when we look at other postoperative outcomes, so postoperative delirium is an reversible disturbance in mental status that is often sudden and fluctuating, and it's one of the most serious complications in elderly patients undergoing surgery, with an overall incidence ranging from 10 to as high as 50%. Preoperative cognitive impairment and dementia are some of the most important significant risk factors. While smaller studies done earlier have shown a beneficial effect of regional anesthesia over general anesthesia on postoperative delirium, subsequent larger trials and SRMAs have not shown the case. So, postoperative cognitive dysfunction is another entity. It's delirium itself is a risk factor for POCD, and even in POCDs, there's no difference in outcomes between regional anesthesia and general anesthesia. But this is all with the caveat that we give the anesthetic well. So regarding postoperative delirium, I want to just summarize these two studies because these are like two of the largest multicentric trials that have been published. The first is the effect of spinal anesthesia versus general anesthesia and hip surgeries in elderly patients that was published in 2021 in NEGM. And the this was done in hospitals in the US and Canada. Then this was the REGAIN trial. And we also have the RAGA trial, which was done in several hospitals in China, which again looked at regional versus general anesthesia for delirium in patients undergoing hip fractures. And both these studies have shown that the incidence of postoperative delirium is not different between spinal anesthesia and general anesthesia. So when we look at cardiac morbidity, postoperative cardiac complications are an important concern in elderly patients undergoing surgery. So earlier studies have all consistently shown that regional analgesia and anesthesia techniques have beneficial effects over GA. But the same has not been replicated in more recent trials and SRMAs. And the reason for this is actually quite interesting because now patients are actually sicker, they are undergoing more extensive surgery. So you would expect that cardiac morbidity would improve. But what has also happened is there is a simultaneous improvement in anesthetic techniques as well. So general anesthesia is much safer now than it was maybe 20, 30 years back. We have better care practices, we have better perioperative guidelines, better postoperative care, as a result of which the small effects, the small aspects of general anesthesia being unsafe to the patients is no longer true. However, in patients undergoing lower limb revascularization procedures for peripheral vascular disease, as well as lower limb amputations for the same conditions, in these patients, regional analgesia techniques have been shown to be beneficial. So they not only have been shown to decrease the incidence of intraoperative hypotension, intraoperative blood loss, and the requirements of perioperative vasopressors, but they've also shown to have a marginal effect over surgical outcomes itself by causing sympathetic block below the level of the, at the level of the surgery itself. So it improves blood flow, reduces vasospasm, it improves rheology, and have been shown to improve Doppler findings in the reperfused limb. But it has not translated into long-term improvement in outcomes. So basically what we know regarding cardiac comorbidity is that we know the positive attributes of regional anesthesia and analgesia. It has been shown to improve postoperative analgesia, it reduces neurohumoral stress response, reduces hypercoagulability and perioperative blood loss. All of these factors have actually are shown to reduce myocardial ischemic stress. So likewise, earlier studies also have shown that regional analgesia, particularly neuraxial blocks, have reduced incidences of DVT and PE. So this paper was one that I found in 1995 that was one of the first papers that actually looked into this. A subsequent SRMA done in 2000 summarized the evidence base for all these studies and showed that regional anesthesia was beneficial. But can this data be translated into today's practice? The answer, unfortunately, is no, because the SRMA done in 2000 summarized study findings at a time and age when routine thromboprophylaxis was not standard of care. So most of these patients didn't receive any heparin or LMWH in the perioperative period, which is no longer acceptable. So today, globally, there's been a reduction in the incidences of DVTs and PEs because of extensive use of risk assessment scores. So many of the elderly patients who are admitted for urgent or elective surgeries would qualify to have high risk of DVT and PE, and all of them receive thromboprophylaxis. So the effect size in terms of how much regional analgesia techniques actually have a say over reduction in DVT and PE incidences is still low, but since we know that there is a theoretical basis behind it, regional analgesia can be used as adjuvants to reduce the overall risk of DVT and PE, but they cannot substitute thromboprophylaxis in the perioperative period. So when we come to other outcomes such as patient satisfaction, surgical outcomes, SSIs, length of stay, hospital theater efficiency, and health costs, the literature is very limited. We don't really have much information about how regional analgesia techniques will improve these data. Now, it's very difficult to conduct studies to look at these factors, and many of these parameters are very difficult to define, and they're all variably defined in different centers. So more data is awaited regarding the effect of regional analgesia techniques on these. So to conclude, regional analgesia and anesthesia is intense and site-specific and can have fewer side effects than systemic medications. The skills and the expertise of the attending anesthesiologist cannot be underestimated, and regional analgesia, when used well, can provide many benefits beyond simple analgesia. Now, some of the aspects of this seems theoretical and intuitive at this point of time, and more hard data is awaited. But till the time that we have such information, what is needed is a tailored approach, which is patient-centric. Thank you.
Thank you, Vinesh, for
Thank you,
your
sir.
wonderful presentation and with all review of literature. No, the question was asked by Dr. Jitendra about role of regional versus general anesthesia. I think I'm very much comfortable with regional anesthesia. And although the evidence says that there is no difference between regional versus GA as far as morbidity or mortality or 30-day or 60-day mortality is concerned. In fact, recent we did one study, that was a DNB thesis, where we have compared general anesthesia versus regional anesthesia, that is spinal and epidural anesthesia. And we found that the 30-day mortality, this was 60 patients only, 30 each, 2 in spinal epidural and 1 in this general anesthesia, but it was not significant. But more importantly, the blood loss was more with general anesthesia, so more patients required blood transfusion as compared to general anesthesia. The other parameters, like as he said, postoperative delirium, there was no change. In fact, the recent guidelines suggest that once a patient with particularly elderly with hip fracture comes in the emergency, he should be wheeled in immediately to the OT because it is a hip attack. The time period is about 6 hours. If you do this surgery in 6 hours, there comes the role of surgeon. And then the morbidity and mortality is far, far less as compared to those who come very late. But if the patient is on anticoagulants, then of course one has to wait. But still, no say that even if the patient is in clopidogrel, you can give spinal anesthesia safely. Previously, it was told that the incidence of this was about 1 in 1 million spinal hematoma, but I think it's very, very low, difficult to say. But we in our center always stop clopidogrel 4 days before surgery and accomplish the total hip replacement or arthroplasty. This was one aspect I think we should be clear, but it also depends on the efficiency of surgeon and what does he want, what is his indication in terms of this hip replacement. So both ways, it's a team effort, and there are so many techniques of using this. People are using LMA with various types of nerve blocks very safely in elderly patients. So I think one should give that technique which you know the best, which you can perform the best, which you can administer the best. I think that's the remedy of such patients. You have to have some experience about that. Otherwise, and the post-op care should also be very efficient. And another aspect was the post-op pain. Of course, post-op pain for first 6 hours is better with spinal and epidural, but after 6 hours, it won't change.
Thank you, Dr. Vignesh, for that excellent review of outcomes after regional anesthesia in elderly. I would just like to add a word of caution here. Like we do when we are giving general anesthesia, we always moderate or modify the drugs, dosages, etc. for the elderly. So we must remember that when we are giving regional anesthesia, the techniques may be slightly more difficult in elderly. You will need to ensure that you modify the drug dosages and the volumes in elderly as you do for general anesthetic drugs. Right. Thank you.
Thank you, Dr. Vignesh.
Thank you, ma'am. Thank you.
One thing I would like to highlight about the on-arrival blocks. Recently, we have started giving on-arrival blocks, especially in elderly patients. As soon as they come, we give them pain relief, either with fascia iliaca block most of the time, or at least femoral block, so that they become comfortable. So this is the thing which we have recently introduced, and we find it quite useful to the elderly patients, especially. Thank you.
So regarding the blocks, I just have a point to add as well. So these the fascia iliaca block that's given in the ER, it can be repeated after 6 hours. That's what the guidelines say. So if a patient has received a block and then requires surgery, that's not a contraindication to not do a block again. So if it's been 6 hours, we can still give a block in the intraoperative period and hope that that extends on into the postoperative phases.
Yeah, in sometimes when we give only spinal, we repeat it at the end. So it can be given pre-op, intra-op, post-op. Anytime you can give this block.
So for neck of femur fractures, like we generally don't use catheters in the post-op. Usually, like once the neck of femur fracture is treated, like that's the most effective analgesia technique. Surgery is the most important analgesia and most effective as well. So post-operatively, these patients have much less pain than in the pre-operative period. And particularly with elderly patients, our aim is to mobilize them and ambulate them. So the presence of a catheter will actually impair their proprioception, and it's been shown to cause increased risk of fall in the post-operative period. So generally, catheters are not used for neck of femur fractures. Of course, there could be other indications for elderly patients receiving fascia iliaca catheters, but not for this patient population. Yes, those have been recommended.
I'd like to make a comment. Pain is something what the patient feels. It's not what you or I as a treating physician feels. So for fascia iliaca block, as you said, it can be repeated after 6 hours. So why give 2 pricks? You can leave a catheter, you can repeat it. Keeping the catheter for post-operative period is your take. But I would still suggest that if you use dilute concentrations with opioids, and that's useful for the elderly, and one of the causes for not mobilization is the pain. We all know about it, and you have already highlighted or underscored the problems associated with such immobilizations. So I mean, it's for the house to consider with lower concentrations of local anesthetic along with opioids, or you may use dexmedetomidine that will help the patient for the postoperative pain management as well.
So using a fascia iliaca catheter has another issue in the intraoperative period because it will be directly in the surgeon's field. So most, like at least like I don't think we do it in PGI, and I worked in 2 centers in the UK and Canada where like the average geriatric like age group like we dealt with was 90. So I mean we never, like those were like high volume centers which dealt extensively with geriatric orthopedics, and we never did intraoperative catheters because one, it's in the surgical field, and secondly, like the aim was all fast tracking and getting patients to get up and move. So and you're right, like patients, the pain is what patients say, and so far what we have is patients don't have pain or as much as pain. Like the data says that pain is much less after surgery than pre-operatively. Thank you.
I think no. Any other question from?
Just wanted to add something about giving regional versus giving an epidural for the colorectal. I know Iraz says not to do it. I'm from Tata, and we have very high volumes of a colorectal. So anyone getting into the abdomen, we put an epidural and they work well. We do not use 0.125. They actually even further diluted down. And by 24 hours, most of our patients are up and sitting. So we do mobilize them by day 2. So we put epidurals for any abdominal surgery that's done in our center.
So I think, thank you very much. We are running short of time. Any one question? No. So I think there are so many views about post-op pain relief or anesthetic technique, use of regional anesthesia versus epidural, use of ultrasound guided blocks. So ultimately, question is, whoever knows the best, he should give it, because ultimately it's the patient's recovery. We have to see it. See, these blocks will keep on coming and then fading also. And to my mind, still spinal versus epidural is still the best. But of course, no, the modernization has come and newer machines have also arrived. People are doing it. No, you will see conferences every week in ultrasound guided blocks in some part of the region. So it is becoming more popular and all that. So choice is when you get such type of patient, I'm talking elderly patients, of course, you have to give your best, whatever technique you choose. Thank you very much for your patience here.
Thank you, chairpersons and speakers, for an engaging and enlightening session. Now, I would like to invite Dr. Ravneet Gill to kindly felicitate Dr. Y.K. Batra and Dr. Sandhya. I would like to invite Dr. Ananya to kindly felicitate Dr. Suman Arora, Dr. Manpreet Singh, and Dr. Vignesh Ashok.
Without much further ado, we proceed with the inauguration ceremony. On behalf of the Society of Aims Mohali Anesthesiologists, I extend a hearty welcome to our distinguished attendees. We are deeply honored to have with us today our chief guest, Dr. Y.K. Batra, Senior Director, Department of Anesthesia at Max Hospital Mohali, Dr. Navdeep Singh Saini, Medical Superintendent, AIMS Mohali, Dr. Vijay Bhagat, Senior Medical Officer, District Hospital Mohali, and all our esteemed faculty members, delegates, and my dear friends. It is with great gratitude that we gather here to officially commence this conference with promise to be an enriching journey of shared knowledge and advancement.
As we gather in the reverence and celebration of knowledge and wisdom, to commence, we invoke the blessing of Goddess Saraswati, the divine embodiment of learning, creativity, and eloquence. I would like to invite Dr. Satinder, Dr. Sargampreet, Dr. Ritika Singh, and Dr. Divanshi for the Saraswati Vandana.
ज्ञानदायिनी अम्ब विमल मति दे। जग सिर मार बनाए भार वह बल विक्रम दे। हे हंस वाहिनी ज्ञानदायिनी अम्ब विमल मति दे। साहसशील हृदय में भर दे। जीवन त्याग तपो में कर दे। संयम सत्य स्नेह का भर दे। स्वाभिमान भर दे। हे हंस वाहिनी ज्ञानदायिनी अम्ब विमल मति दे। लव कुश ध्रुव प्रहलाद बने हम। मानवता का त्रास हरे हम। सीता सावित्री दुर्गा माँ फिर घर घर भर दे। हे हंस वाहिनी ज्ञानदायिनी अम्ब विमल मति दे। अम्ब विमल मति दे। अम्ब विमल मति दे।
Thank you for such a wonderful performance.
Now, in the presence of this auspicious gathering, we stand at the threshold of a significant moment where tradition meets the promise of new beginnings. The lighting of the lamp, an ancient rituals that transcends cultures and eras, holds profound symbolism signifying triumph of light over darkness and knowledge over ignorance. I invite our dignitaries, Dr. Y.K. Batra, Dr. Vijay Bhagat, Dr. Navdeep Singh Saini, Dr. Sukanya Mitra, Dr. Payal Narayana, Dr. Sandhya, Dr. Lalita Gauri, Dr. Pooja, to please come and light the lamp.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः। शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः। शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते। दीपज्योतिर्नमोऽस्तु ते। दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः। दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः। दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते। ओ दीप ब्रह्मरूपस्थं ज्योतिषां प्रभुरव्ययः। ओ दीप ब्रह्मरूपस्थं ज्योतिषां प्रभुरव्ययः। आरोग्यं देहि पुत्रांश्च पतिं स्वच्छामि मे सदा। रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत्। रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत्। यस्य तिष्ठिद्गृहे दीपः तस्य नास्ति दरिद्रता। शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः। शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः। शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते। दीपज्योतिर्नमोऽस्तु ते। शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः। शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः।
Thank you, dignitaries. I'd like to add that our Chief Patron, Dr. Bhavneet Bharti, Director Principal, AIMS Mohali, is unable to join us today due to prior commitments. Ma'am extends her warm regards and best wishes for a successful conference and looks forward to connecting with everyone soon. Now, I would like to request Dr. Ravneet ma'am to kindly introduce our chief guest, Dr. Y.K. Batra.
Good morning, all, and welcome to everyone. Today, it's a privilege and an honor to invite a chief guest on stage, and I present to you a true luminary in the field of anesthesia and critical care, Dr. Y.K. Batra, sir. With a career spanning over 4 decades, Dr. Batra has not only shaped the landscape of anesthesia in India, but also set global benchmarks in pain management and critical care. Dr. Batra served as the head of the Department of Anesthesia at PGIMR, one of the India's premier medical institution until 2015, where he nurtured generation of anesthesiologists and led groundbreaking research. Today, as the Senior Director of the Department of Anesthesia at Max Hospital, Mohali, he continues to be a guiding light in the profession. His contributions have been recognized internationally with prestigious fellowships, including the WHO Fellowship in Pediatric Anesthesia and Intensive Care at the Hospital for Sick Children, Toronto. Beyond his clinical expertise, Dr. Batra's leadership in the Indian Society for the Study of Pain, where he served as a president in 2012 to 2013, stands as a testament to his commitment to advancing the science of pain management. In recognition of his lifetime of contribution, he was honored with the prestigious Lifetime Achievement Award in Pain Management as well. Ladies and gentlemen, it gives me immense pleasure to call upon Professor Batra sir for a welcome address.
First of all, I never knew that my name appeared in the list, and I will be invited for chief guest, but this is a part of a job. One has to accomplish it. I may be senior in age, but I'm not senior in professional skills. Most of you are senior to me also. So first of all, I must compliment and congratulate the team of anesthesia at this hospital for organizing this conference. In fact, this is my third conference here, and more may have been inaugurated by other persons too, but this department has become too academic, of course, clinical too. I'm very much privileged and honored to be a part of this inauguration ceremony. And I see a lot of distinguished faculty here sitting in front of us, and my dear friends and colleagues, and also delegates. When she spoke about as chief guest, suddenly I reminded of since the conference, and this theme is on care, that is current researches or current advances in regional anesthesia and elderly patients. So I thought that about in early 70s, we used to give landmark techniques as blocks, and the most popular was brachial plexus block. That is supraclavian technique. At that time, we used to give, and it was also called, I don't know how many knew about spinal anesthesia of the arm. So now things have changed. Ultrasound has come to his age. To my mind, feeling a bone and seeing a bone is different. See, if you feel yourself, like if you see pulse, palpate the pulse, that is better rather than seeing with ECG. You have to combine the two altogether. So with landmark techniques, you see, if you compare with ultrasound guided, of course, there will be some comorbidities, some complication might occur, like in supraclavicle we might have pneumothorax, but in a experienced persons, of course, the incidence is not too much. And if you compare the two techniques, of course, take an ultrasound, you see each and everything, and then place your local anesthetic agent. But in landmark technique, you have to give a larger volume of local anesthetics. But ultimately, pain remains the same in both the situations. Your VAS score, if you have applied your this local anesthetic into an appropriate place, the VAS score remains the same between the two. Of course, if you compare the two with sensory and motor block, then that will be more prolonged in case of ultrasound guided blocks. So there is a difference between the two, but we must also learn landmark techniques too. In fact, in most of the conferences, we should have compare the two techniques altogether. In fact, in one conference, we should have only our theme was on landmark techniques, and one can do in cadavers. So in this way, we can be better acquainted ourselves with these regional blocks. Of course, no, things have changed. We have got, in 70s, we were getting only 5% lignocaine as local anesthetic for spinal anesthesia. But no, we have variety of local anesthetics. We have ropivacaine, bupivacaine, levobupivacaine, and we know the various indication of these local anesthetics at different places in different patients. So things are changing gradually. There is advancement in anesthesiology and regional anesthesia, good for the patients, but basics remains the same. And not only this, the armamentarium has changed. See, the needles we used to have, see, very thick stainless steel needles, which were repeatedly autoclaved, whether it is spinal needle or epidural needle. And for this, we used to give spinal and epidural anesthesia. And at that time in 70, there were no catheters also. So, lignocaine, of course, you can't give more because of its toxicity. We have seen these reactions too. So, we have no better epidural needles, better spinal needles, better epidural catheters. Of course, we have better machines, gadgets. So things have reached to a certain great extent for the success of the surgery and for relief of pain. Now, another thing which has come into picture in these patients, multimodal analgesia. I think that's another thing which has done a substantial relief of pain and free from opiates. And this will be useful, as Dr. Vignesh has already talked about, in elderly patients. So we have opiate sparing effect, use of ketamine infusions, use of lignocaine infusions. All these things have been used for multimodal analgesia. And more importantly is ERAS guidelines, which has come in elderly patients, which will reduce the time for admission and early discharge. So new innovations, new techniques, they are coming and changing the prospects of each and every patient, and also decreasing the morbidity and mortality, plus the expenditure of the patients. So all these things we have to see and learn. But more importantly is that I've already said that there are a large number of techniques in this hip surgery and whatever. And in fact, there are as many as anesthesiology as the number of techniques. So we have to be very precise, very safe, give that anesthetic which is adaptable to that particular patients. Then only we can give success to the patient. So I again thank my colleagues from this place for inviting me for this beautiful conference, which I love by heart. And I am sure that these techniques will be helpful, and our younger generation will definitely adopt to these techniques and which will be benefit to each and every patient. Thank you very much.
Thank you, sir. We are indeed inspired by your words of wisdom and expertise, which I'm sure have resonated with all. Now, I would like to request Dr. Pooja ma'am to kindly present a token of gratitude and appreciation to Dr. Y.K. Batra, sir.
Now, I invite our medical superintendent, Dr. Navdeep Singh Saini, to address the gathering.
On behalf of Dr. B.R. Ambedkar State Institute of Medical Sciences, very good morning to all our esteemed chairpersons, faculty from very premier institutions. We do welcome you. I'm very pleased with the topic chosen by our anesthesia colleagues, care for the elderly. This geriatric care, patient care was not very attractive field when we were doing our graduation and post-graduation. I do remember when my friend was offered fellowship in CMC Vellore for geriatric medicine in 2002. But being not very attractive field to pursue the career, he refused. But 2 decades down the line, we always think that that was a wrong decision. From the surgeon's perspective in this anesthesia conference, I would like to share 2 experiences of mine. Once I attended to a patient with huge inguinal hernia. Patient was 90 plus. So after taking clinic for MBBS students on that patient, I sent the patient to PAC clinic, and to my surprise, family came back and said they are not willing for surgery. I probed a little bit further. Then they said that patient was from ECHS background, and patient son told us, our anesthesia colleagues said that there is a risk of surgery because of the age, and whole family is depending on the pension of that patient. So they don't want to take the risk. It took around 20-30 minutes to convince them, then talk to the senior anesthesia colleagues, and that patient was taken up for the surgery next day. So issues with the elderly are not only medical issues, they are social issues also. One of the patients we received from Himachal, elderly relative around 87 years old, ruptured abdominal aortic aneurysm. So when we were preparing her for surgery, so definitely we have to take death on table consent for that. Family was very understanding. So they said, okay, we want to talk to our mother first. I was witness to that conversation, and I will never forget that conversation. That elderly lady requested only one thing. अगर मेरे को कुछ हो गया मेरे जाने के बाद मेरी गाय का जरूर ख्याल रखना. I never forget that thing. And luckily, whenever that patient was coming back in follow-up period, after every 3 months, she used to bring the CG of that guy for all the medical our team members. Once again, I do welcome all of you. I will not be taking much time. I am very sure this will be a very enriching experience for all of us. Thank you, anesthesia department. Thank you all.
Thank you, sir. I would like to request Dr. Ritu ma'am to kindly felicitate, sir.
I request Dr. Ravneet to felicitate Dr. Vijay Bhagat, Senior Medical Officer, District Hospital, Mohali. I now invite Dr. Pooja to propose a vote of thanks.
A very good morning to all of you. It's an honor to welcome everyone to the conference of current advances in the regional anesthesia for the elderly. So on behalf of the organizing committee, I'd like to extend a warm welcome to all of you, the esteemed speakers, the panelists, the participants, and distinguished guests. As we know, the elderly population represents a unique and rapidly growing demographic population with complex healthcare needs. And regional anesthesia offers a promising approach to manage the pain and the surgical care and thus improve the outcomes in these patients. However, it also brings about the challenges due to age related physiological changes and coexisting health conditions. So, it's these very challenges that bring us together here today to share our knowledge, examine the latest advancements, and discuss the best practices that can help us enhance the quality of the care we provide. So, from the advanced nerve blocks, and which we'll be sharing in the sessions, and the real-time imaging guidance on our hands-on workshops, each session promises our understanding of the safest and the most effective ways to practice anesthesia for the elderly. I would like to express my deepest gratitude to all our speakers, the panelists, the workshop facilitators, and sponsors for their invaluable contributions, and to each one of you for joining us here today. I have no doubt that the discussions we have here will leave us totally enriched and better informed and ready to implement new knowledge in our practices. So, thank you, and once again, welcome to all of you.
Thank you, ma'am. Now I will request the gathering to kindly stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
We shall now proceed for a cup of tea before convening the next sessions at 10:30 a.m. I also request the chairpersons of the scientific committee to proceed to the committee room for the commencement of e-posters, e-paper presentations after the session.
Hello. 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 Hello.
रखना है इसमें बॉटल्स भी रख दो
इमीडिएटली आफ्टर फिर नेक्स्ट सेशन के लिए हमें
We need 2 mics, hand mics.
हेलो प्रियंका चाय वाय